Okay, good evening, everyone. This is the National Hispanic Medical Association's first session of a series of virtual briefings that will be looking at COVID-19. Okay, we have a lot of great lineup of speakers, and I just want to give a couple of housekeeping messages. One is that we have all participants on mute, and we are going to ask for questions of from the audience through the chat function. And at the end, after the speakers finish, we will have a few questions posed to them, and I'm moderating the session, so I'll get your questions. And I apologize, we won't be able to get to everybody's questions, but we will try and answer them afterwards if we don't get to all of them. The second thing I wanted to let you know is that we have CME, continuing medical education for doctors and others who can get continuing medical education. And this is the notification from a Medco, and it's just basically an acknowledgement that you'll get 1 hour of credit and where to go. And we are going to send information coming from Ben Milano after this is over, probably tomorrow, with a thank you notice and the notification on how to get your CME. So what I wanted to also explain right now is that we have many partners who have made this possible. And I know we don't have a slide with all their names, and it's actually just an initial list. But the National Hispanic Medical Association is very appreciative of all of our partners. And for this session, we have the All of Us research program from the National Institutes of Health, the Centers for Disease Control and Prevention, which is known as CDC, specifically the HIV division, Amgen and their cardiovascular division, the Aetna Foundation and CVS Health for the vaping projects that we do, and Pfizer Inc. and Compassion and Choices. And we'll have a few more partners as we move along in our webinar series. The webinar series will be monthly, the last week of the month. Tonight was a Thursday. I think the next 2 months will be Wednesdays, and then we'll go back to Thursday. And we're very excited about hearing from our doctors who are experts on solutions for COVID-19 and the patients that they have seen. I'm going to introduce them one by one, and then they will go over their slides. And I think I just have a few slides right about all of us. Ben, do you want to move to the next one? So the All of Us research program is very important. 1 million people are being recruited over 10 years to be followed so that we can understand diseases like COVID-19 and other diseases and how they impact our lifestyles and how people, how they journey through a chronic disease or hopefully no disease. But anyway, just wanted to point out the joinallofus.org is the website there at the bottom, or allofus.nih.gov. Next slide. So this program is a historic longitudinal effort to gather data, like I said, from 1 million people living in the United States to accelerate research and to improve health. And we're going to look at lifestyle, socioeconomics, environment, biology, which is what is known as precision medicine. But more importantly, this data is going to have an open access. The next generation of researchers will be able to use this information from, with all kinds of privacy involved. But instead of having to go after finding your own patient population for a research project, this is going to be a phenomenal research opportunity for young researchers. Next slide. So the mission is to accelerate health by looking at individual prevention, treatment, and care. I'm not going to read all of this, but basically it's a very comprehensive approach to looking at your lifestyle and also asking people for their blood and urine and stool samples and following them each year for 10 years. Next slide. So participation is open to all. Everybody in the audience, you can have your patients be part of this, your families, yourselves. We are very interested. We're a partner, a national partner with NIH's All of Us program. And we're very interested in having more Latinos and African Americans, Asians and Native Americans, especially, to have more diversity within this research project. Participants are called partners. Trust is through transparency, lots of access to your own information, as well as I mentioned, privacy and a chance for real research on a lot more people than we usually see. Research projects out of NIH or FDA and what they call clinical trials usually only has less than 5%, less than 2% of minority people. Next slide. So the All of Us is going to invest in data, and it has its own data hub. It already exists. They have been recruiting and registering people now for over a year. And I think that it's important to realize that it is public and it is being held accountable, again, with privacy in mind. Next slide. The enrollment is over 300 participants already, and 80% of the current participants self-identify as belonging to one or more populations that has been historically underrepresented in biomedical research. So that's phenomenal. And nearly 400 active enrollment clinics across the country. The Veterans Administration is involved, the community health centers are involved, the Indian Health Service, lots of organizations, nonprofits, as well as hospitals and practices across the country. So take a look at the website and get more information. Next slide. And again, this is just another mention about the importance of what's coming in 2020, which is the data hub to be able to look at the data that's already being collected to see if you can use it in your research project. And next slide. So this is now the transition to our webinar on COVID-19 cases. Just to mention the context, the National Hispanic Medical Association was formed to be able to provide empowerment of physicians and others who take care of Hispanic patients to better understand all vulnerable patients. And tonight we're very happy to show that in California, New York, and Louisiana, the three places where our speakers come from, lots of cases, of course, but more importantly, at the bottom, you see the population of Hispanics and African Americans. Well, the population of Hispanics for California, 39%, for New York City, 34%, New York State was 14%, Louisiana is about 2%. So smaller numbers there. But the percentage of the cases you can see are high. So for California, it's almost comparable. The percentage of deaths. The percentage of deaths in California for Hispanics are 34% deaths. For New York City, 14%, and Louisiana, 55%, I guess, African American. At any rate, I don't want to dwell on these numbers, but just to tell you that we have a long way to go, and we are here to hear some of the best solutions and strategies from our speakers. So our first speaker is Dr. Nareda Correa. She is an OBGYN and a family practitioner, an associate clinical professor at Einstein College of Medicine in the Bronx. And she's also an attending physician at a hospital called North Central Bronx Hospital, and she's the CEO of Eastchester Medical Associates. She went to medical school at Einstein. She actually is a nurse even before she went to medical school, which is great. She got her nursing degree from New York University, and Nellie's here to talk to us about women's health and private practice. Nellie?
Good evening, everybody. It's a real pleasure to be here. Thank you, Elena, for that very nice introduction. I want to talk to you about two aspects of it, which are part of my heart and soul. One of them is private practice and what's happening specifically in New York City, but I think is throughout the United States by what I have been reading, and that is that private practices are suffering. The other is the aspect of women's health and how the COVID-19 pandemic has affected women in our communities. Next slide. So I want to start with the social determinants of health, because we know from back in the day that we have been talking about health disparities and some of the social determinants that our communities of color are in some ways impacted in the way that their health goes. So just to review, some of the things that are required are economic stability, education, social and community participation, health, access to health care such as health insurance, and also neighborhoods and environments that are safe for our children to grow and play in. Next slide. What has happened in this pandemic is staggering in terms of our communities. This is a map of New York City, and the very, very dark areas, which include Brooklyn, Queens, and the Bronx, are the ones that demonstrate the impact that this pandemic has had on our population. From the beginning, we started to see that many of our patients coming to North Central Bronx and to some of the health and hospitals and other hospitals were Latino patients or African-American patients. And we started to think about, well, why is this happening and what is going on here? Why are our patients, are people more sensitive to this virus than others? Next slide. So, you know, health disparity in COVID is real. So according to the data in New York City, 34% of the people that have died are Hispanic, and 28% of the people who have are African American. This is a huge burden of more than 50%, almost 60% of the population of the city, which is of color, is dying. So what is going on here? Next slide. When we go back to look at the social determinants, we can see how our communities have been impacted. First of all, many of our people are first responders. So we have police, we have nurses, we have service workers, building workers, cab drivers, MTA. So a large number of the people that were initially impacted by this virus were people who were out there in the front. Also, people that have been impacted are crowding. You know, if we have some families that live maybe 2 or 3 families in one apartment, and that's the nature of how they are living. We have had a huge immigration crisis over the past several years, and this has impacted on how our immigrant populations, who are largely Hispanic in the Bronx, access healthcare. So they are afraid to go in, and they wait and they wait, and then by the time they come in, they may be a little sicker than they would have been if they went in initially. Again, loss of jobs is very important. Those who are in the service front suffered from getting the disease, and the rest of us suffered from losing jobs because we were not needed. We are generally not a population of workers that work from home, so that we were highly impacted. You know, restaurant workers, people who are in service positions can't work from home. They have to be out there. The schools closed, so that put an additional burden on our families because the children were home, and so were the parents, and so was everybody else. So that also impacts on education because many of our kids didn't have iPads or electronics or access to Wi-Fi. So we had some very generous people that donated Wi-Fi and iPads to the children, but we still were impacted in that way. A breakdown in communication so that people, if you don't speak the language and you don't hear about things, sometimes you respond a little later. And access to healthcare is key because right now we are fighting to keep the Affordable Care Act available to those families who don't have insurance. So if you don't have insurance, sometimes you're afraid of the bills that you will get and you don't go to the hospital, to the doctor. Next slide. So in our private practice, this is our group. And just 2 months ago, we were having a little birthday party for one of the doctors. But a few days after this, we had to close. 2 doctors on our floor were taken with the coronavirus and they had to close their office. And we closed our office and went to a way that we could access our patients. We applied for the Paycheck Protection Program, and we were able to get it on the second wave, and that actually helped us a little bit. But when you're just dealing with paying for the paychecks and have no income, 0 income, then rent, malpractice, and other expenses pile up. And the problem with this too is that the patients are afraid to come in. So therefore, even if you were open, they were not going to be coming in to be checked. And if you have all of the routine health care and the preventative care has gone by the wayside. The other thing is our patients or our communities prefer the Latino doctors who are networked in the Bronx, in Queens, in Brooklyn, and they prefer going there than to the neighborhood clinics. And generally, the federal laws have favored federally qualified health centers and neighborhood health centers over the private practitioners. Next slide. And I think I mentioned some of this. Some of the things that were really important is for us to have signage and resources in Spanish so that our patients could communicate. Our dental office in the building closed down, and where our office was only open 1 day a week, and then the staff took their phones home and they were able to answer all of the calls to the office from their homes, and we were able to keep them on payroll. Personal protective gear became a huge problem because we didn't have access to where to buy it. And, we couldn't take it from hospitals or anything like that. So getting masks, our staff learned how to make masks, and we gave out masks to patients. They were very creative in making wipes. They started to throw alcohol in with wipes. And so we were very creative in helping us to protect ourselves and also helping us to protect the patients. Next slide. So now moving to the hospital. We only started testing for COVID in mid-April. And what I can show you here is that of those tested, 38% were positive. It's a little better now. This month, the cases have decreased and maybe 25%. But at the beginning, when we were testing, about 30 to 40% of our pregnant women were COVID positive. Now, this raised a tremendous crisis and conflict for women because in the maternity services, we're used to having the partner and sometimes the mother and everybody present because it's a family celebration and we're having a delivery. Because of the lack of personal protective gear, we had to limit the number of people. So it would only be the partner, and that person had to stay for the duration of the labor. And if they left, they couldn't come back. So it was really, really painful to see sometimes women alone. We developed a video teleconference system so that the nurses could talk to the patients, even from outside the room. But again, this is OB is a celebratory thing, and it really put a crunch on what we could do. The other issues were handling the baby. Deliveries are very touchy-feely things, and how are we going to deliver a baby, and then the baby had to be taken away immediately from the mom and placed in an isolate, and how do we do breastfeeding, and on and on. And as we went along, we also discovered that this disease had coagulopathic changes in the body, so that we had to begin to protect women who tested positive against having DVTs and pulmonary embolisms, which could be. Pregnancy is already a hypercoagulable state, so therefore they were at higher risk, and we had to think. And then if you compound the insurance issue and people going with a prescription for Lovenox to the pharmacy and they're not going to be able to fill it, it was a double jeopardy. So we had to try to get our pharmacy in the hospital to honor some of these prescriptions so that the patients can, because the coagulation was recommended was for 6 weeks. So that's a lot of drug, a lot of Lovenox. Next slide. So lesson learned, we needed personal protective gear, and we need to really take seriously, because many of our nurses and our workers became infected with the virus. And so we had to make sure that we had hats and that we had shields and masks, and that we protected ourselves and that we protected the patients. Eateries were closed, so we had nothing to eat, but there were very kind donors that gave food. Essential workers, housekeeping and all that, had to be trained. All of us had to be trained on how to don protective gear and how to use it. So many of the areas in the hospital were converted to COVID unit. One of our nurseries was converted to a COVID unit. Our PACU was converted. Next slide. So code bells rang every day, several times a day, and we became very sad every time, because we knew that this was somebody who was having either an intubation or a heart attack. Fear was in our eyes all the time over the mass, and many died, and some were our staff and people that we knew. And those who died in the Bronx were our communities, and those infected were the people in our community. Next slide. So the human toll was great, and it can't be explained. It can be explained in many ways, but the reason I started off with the social determinants of health is because we know that there were many pre-existing problems in our communities even before this pandemic. So this just exacerbated it. So high infant and maternal mortality rates are something that we've been talking about in African Americans for the past 2 years. High incarceration, an increase in chronic diseases like diabetes. If you're obese, diabetic, and hypertensive, which is a large part of our population, you're going to be more likely to be infected with this virus. Thankfully, many people will get, not as severe a case. Only about 15% of people needed to be hospitalized, but our frontline workers, who were people of color and often had some of these problems, were a large proportion of the victims. So I'll stop there. Thank you very much.
Next speaker is Dr. Sylvia Preciado, and she is from the Los Angeles area, the city named Pasadena. She's an internist who went to school at the University of Nebraska Medical School and UCLA undergrad. She is now the co-chair of a COVID-19 External Surge Committee and Operation COVID-19, and she'll tell us about that. And she also works with the Huntington Memorial Hospital in Pasadena, and she's a new board member to our board of directors. Sylvia?
I enjoy being a board member now. Good evening, buenas tardes. I am Sylvia Preciado, Dr. Sylvia Preciado, an internist in Pasadena in private practice, and also co-chair of Operation COVID-19 with Dr. Wafa Al-Rashid, who is also an internist and a professor at Huntington Memorial Hospital. And also we also had an infectious disease doctor who serves as our liaison, Dr. Arvid Underman, a professor at USC. First slide. Operation COVID-19 is a group of practicing physicians who teamed up to address areas of vulnerability related to the novel coronavirus within our nursing homes, assisted living facilities, and our community. Next slide. Here you can see my friend, Dr. Wafa Rashid on the right, co-chair, as she swabs a patient at our drive-through that we started on approximately March 1st. Next slide. Some of the goals of Operation COVID-19 was mitigation via testing of staff in nursing homes and community to reduce infection rates, COVID-19 testing at nursing homes, obtaining donations of PPE, which was shared with our nursing homes because we saw the need early in late February, early March. Reducing admissions to the emergency room and hospital, and utilizing other services. As you can recall, we had a shortage of testing kits early on. Our group was able to find private labs, and we were able to obtain over 1,000 nasopharyngeal swab kits so that we could test as many nursing home patients early. By doing that, by testing the nursing home patients, we assisted in decreasing the number of patients that were going to be transferred to the emergency room unnecessarily and increased the risk of infecting the employees of the emergency room. We also were immediately able to isolate COVID asymptomatic nursing home patients from COVID symptomatic patients at a nursing home, but it wasn't easy. We distributed and found and collected from our own patients over 2,000 pieces of PPE and successfully got them to the nursing home. So that was absolutely fabulous, especially in LA. But the most important thing I want to mention is that we actually decreased the anxiety for the staff, the nurses, the LVNs, the cooks, the housekeepers had so much anxiety that there are many of them that quit during this pandemic. So by testing the patients, we were able to alleviate their fears and keep them working, which was very important. Next slide. One of our doctors, Dr. Eva Poon, came up with a registration form that we use for our own patients. And I won't go through this in detail. But as we started to learn more about the state of our nursing homes, we started to give this same questionnaire to the employees of the nursing home. And what we found was that many employees work 2-3 jobs. The next thing we discovered is that food service and housekeepers weren't given enough PPE. They were not protected. And we also discovered that many employees who work in these nursing homes are blue-collar workers, and to ask them to isolate is almost impossible when they have 2-3 families living in the same home. So we still are collecting a lot of data, and I'm hoping that at the end of the year, I'll be able to share more information with you. Next slide. This is just a list of some of the assisted living facilities and nursing facilities that we visited personally. We entered these facilities. We actually saw what was going on in these facilities. Now, our community, our LA Pasadena community, has the luxury of more nursing facilities to place our elderly. However, when in reality, it was definitely not the safest place during a pandemic. While LA County has over 809 long-term care facility beds per 100,000 residents, Pasadena almost has triple, 2,376 beds for every 100,000 residents. Next slide. So what did we learn about the risk for elderly patients? Number one, there was a higher incidence of infection in nursing homes in certain communities. It appeared that nursing homes in less affluent communities had much higher infection rates. My observation also is that in less affluent nursing homes were mostly occupied by Latinos and African Americans. The next thing I learned about going into these nursing homes is that the primary care doctor, all of you should have a primary care doctor. Primary care physicians are the most important, essential part of the care team. Based on my experience in going into these nursing homes, early education and proper protection of your providers who are taking care of this most vulnerable population, make sure that we ensure the safety of these patients and caregivers. And no one I think will argue that a primary care doctor knows the patient better than anyone else and is able to communicate with the family. The next thing we learned is that the staff is not and was not adequately trained in proper PPE usage, and sanitation is a key element in preventing transmission of this virus. One of my patients the other day said to me, sanitation is one of the best gifts that we have for humanity. If we could just learn to properly wash our hands, if we could just learn that when we have a cold or we have an infection to keep away from others, we are going to make the transition to the new normal much easier. Because many employees work at several jobs, they were definitely a key significant concern regarding source of transmission. Many employees were asked to give up 2 of their jobs to continue working at one nursing home. You could imagine the impact that that had on them and their ability to take care of their families. And the last thing I learned is that from my experience is that you have to somehow partner with your health department because they can help combat the disease. Next slide. Cardiovascular diseases are the #1 killer in the United States. Just ask my sister, Dr. Marta Preciado, in the Boyle Heights area, who is now starting the COVID-19 process there. Our elderly Latino population has a high incidence of cardiovascular diseases, in addition to other chronic diseases. And already our Latino community is at high risk for poor outcomes from everyday illnesses. This places our elderly Latino patients at an enormous disadvantage in combating this novel coronavirus. Being ill-prepared to address this crisis just magnifies the challenges. My hope is that more physicians, more medical students, more students in the community will see this as a call to duty and not wait to be asked, but get out there and participate on the front line when challenges like this occur. Next slide. COVID-19 exposed our areas of weaknesses, especially in regards to caring for our most vulnerable population, the elderly. We have to re-engineer how we work within the SNF environment. As we start, these are my suggestions. #1, and I know that Dr. Elena Rios agrees with this, policy and procedure must be amended at this moment to address these issues. City council, health department, hospitals, and nursing homes must partner early, not late, but early, in order to prevent the ongoing surge, because it's not over, and continued spread of this deadly virus. Management teams must include the appropriate personnel, and they must understand their individual roles during times of crisis. Under the leadership of nursing home administrators, director of nursing, medical directors, these individuals need to have a clear understanding of and set guidelines to help continue the fight against any future pandemic. Physicians must participate. Just to hear this, physicians must participate in the decisions regarding care of the patients, the structure of the care environment, and training of the accessory health team, LVNs, medical assistants, therapists. I cannot tell you how many times I walked into a nursing home and I said, I want to watch you wash your hands. And you would be amazed at how many did not know how to adequately wash their hands or don and doff PPE. And that's what we're continuing to do. We must also, with our elderly population, especially because they've been so isolated, we must involve and educate the family members who can be a big source of transmission of the virus. And there's one more point I want to say, since we're speaking to a lot of doctors, students, medical students, we must train. We must train. This is a huge mission, and I know Dr. Elena Rios is doing a fabulous job at working on this. We must train and mentor our future Latino physicians, as we have proven over and over and over again. We are the ones who know how to deal with this community. We are the ones who know how to speak their language, understand their culture, and therefore we need more of us. And next slide. I will end by just saying that the general community has a very important role in the effort to address this COVID-19 disease. Number one, we have to, each and every one of us has a responsibility to explain the consequences of COVID-19 infection in high-risk groups, SNFs, lower income Latino communities, African American. We must do it. We can't wait for anyone else. We must do it, and we must do it now. We have to teach our community members. We need to teach our families techniques to prevent transmission, especially as we begin to go back to work. We must also help our families do what's right when they get sick. We have instilled such a fear of this COVID virus. I was scared too, but I made sure I had the proper protection. We already have a vulnerable Latino population in this country who has had limited access to healthcare. Now you add coronavirus and you add fear, and now we have patients, Latino patients, who are going to the emergency room with ruptured appendix, heart attacks, diabetes out of control. We must help now teach them to transition into a near normal, the new normal, and teach them how to access healthcare. Thank you very much. It was great speaking to all of you.
Whoop. Am I on? Okay, thank you very much. So next we have from the Gulf Coast and the leader of our NHMA Gulf Coast chapter, Dr. Leonardo Seoane, who is the Chief Academic Officer and Vice President of Ochsner Health, and he's the Associate Vice Chancellor for Academic Affairs Louisiana State University Health at Shreveport. And I know that he's local to New Orleans from Cuba, and has all of his internal medicine, pulmonology, fellowships, and medical school training in New Orleans at various universities. And I'll just read a couple: Loyola University, New Orleans for undergrad, and then the Louisiana State University School of Medicine for medical school and residency fellowships. Leo, take it away.
Yep. Thank you for having me, Elena. First, let me say what a privilege and honor it is to share this webinar with Sylvia and Nareda. I've been incredibly impressed by their presentations and quite honestly touched by the great work they've done. So thank you, Sylvia. Thank you, Nareda. What I want to cover is our experience in the ICU and kind of switch to caring for critically ill patients with COVID. And there's three main, I think, big take-home lessons that I would say I wish I knew then what I know now. One is the use of non-invasive mechanical ventilation, whether that be high flow nasal cannula or CPAP or BiPAP, decreases the need for mechanical ventilation. And so I'll show you some data how we used it and how we were able to prevent people from being on the ventilator, and therefore we never ran into a situation where we were short of ventilators. Two, evidence-based therapies for ARDS. Although COVID-19 is new, the way it injures the lung is not. There are many infectious agents that injure the lung very similarly and lead to ARDS. And so I want to address and give everybody some equipoise about, there's a lot in the literature of, well, it's not real literature, there's a lot in the press, I should say, about these different types of injury to the lung, and whether it be a very compliant lung or a stiff lung. And I just want to bring us back to reality and say we can't throw 20 years of research on how to treat ARDS and then share with you some data that says, yes, the evidence-based therapy does work for this disease and this ARDS. And then finally, and it was already alluded to this in Nareda's talk, that these patients are hypercoagulable, and we find in the ICU that this hypercoagulable state has led to significant morbidity and mortality. And it's beyond the DIC and the endothelial injury that they see. We see PE and DVTs also. So talk a little bit about the literature on that. Next slide. So just to give you an idea of how the impact on Ochsner. So Ochsner has 4 hospitals, the main academic medical center, and 3 other community hospitals, including the Women's Hospital in the greater New Orleans area. At our peak, which was about April 7th, we had 230 patients in ICU beds at Ochsner. Today, I'm very happy to say we have 25 patients in ICU beds at Ochsner and only 7 on the ventilator. So we've come a long way. We're all praying and anxiously seeing how, as we go through our phase reopening, and we know that there'll be some relaxing of social distancing, how that is going to play out. Next slide. So, you know, I teach, I'm one of the professors at the Ochsner University of Queensland Medical School, and I always tell the students and the residents and the fellows, look, the best way to reduce ventilator-induced lung injury is to never put them on the ventilator at all. But early on, the recommendations, you know, as this went from China to Europe to the United States, the US was looking at Europe for guidance, and the early recommendations from the European Society of Critical Care was to intubate these COVID-19 respiratory failure patients early. And the thought was you close the circuit and therefore protect your healthcare workers by having a closed circuit on the ventilator. And we implemented that strategy early on too. That was actually our practice act. But quickly we found out some of the things that I was telling the younger doctors, this is my practice 20 years ago, that when we have a bad hypoxemic ARDS patient and we intubate them, they're difficult to sedate because we have to use very small tidal volumes. Many times paralytics is required. And one of the things we absolutely know is that positive pressure ventilation will cause ventilator-induced lung injury. And so even if we find the compliant lung that's out there, putting them on a ventilator over time, it will become a stiff lung. And so we then switched strategies, and we said, well, wait a minute, why should we treat this disease any different? Because there's good evidence. There's a New England Journal of Medicine article by Pratt in 2015 that shows that patients with pneumonia-induced hypoxemic respiratory failure with ARDS, that would have met the German definition for ARDS, with those patients, if I randomize them to high flow nasal cannula or non-invasive mechanical ventilation or the usual care, 100% non-rebreather and intubation, but actually there was a survival benefit, 90-day survival benefit for those patients that got high flow nasal cannula. So now look, this was a culture change because we had told the nurses and we had told the units, and we're saying, look, we're intubating early to protect everyone. And now we had to go back on ourselves and say, well, wait a minute, we're not going to intubate early. We're going to leave people in high flow nasal cannula. And we didn't have enough negative pressure rooms to put everybody in. But we're going to put a surgical mask on the patient to try to decrease the aerosolization. And fortunately for us, we although we were conservative about the way we managed PPE, we never ran out of personal protective equipment. And so we're going to practice the best personal protective equipment. We did not see an increase in healthcare workers getting COVID-19 with appropriate PPE. We did see dramatic improvements, and other people have reported this too. The University of Chicago has similar experience. Some of the institutes in New York and Boston have reported similar experience. We saw a dramatic decrease in the drop in intubations needed when we went to non-invasive modes to keep them off the ventilator, because these patients were basically hypoxemic respiratory failure. So what did we do? So we did some non-intubating proning in certain patients. Now, patient selection is huge there. They have to be awake and cooperative. But sometimes we would prone them with the high flow nasal cannula on. We use BiPAP and CPAP to try to recruit alveoli, as especially for those patients where we thought recruitment was essential. And we allowed some permissive hypoxemia. If the SATs were 88% and they were otherwise doing okay, we were okay. So we weren't quickly intubating patients anymore. And I just want to show you, next slide, kind of what we saw over time. And so what I've got in front of you, the blue line is ICU patients in our ICUs over time. You can see the rapid increase from March 16th to about April 7th with the increase of COVID patients flooding our hospital. The top bars here are available ICU beds. This is just COVID patients. You can see 85% of our available ICU beds were filled with COVID patients. You can also see that we added ICU beds through the crisis, and that if we wouldn't have added ICU beds, we would have been overcome and would have had more patients in ICU beds. But the line is what I want you to focus on. The green bar here is patients in the ICU on the ventilator. And you can see before the lines diverged, before we changed our practice habit from early intubation, about 85% of patients with COVID in our ICU were on the ventilator. When we went and changed our practice habit, you can see the lines diverge. And then this is just a point in time, April 15th, when we're down to 55%. Almost half of patients in the ICU were on the ventilator. We used less ventilators. We saw better outcomes. And probably most importantly is that besides the better outcomes and using less ventilators, is that we also still admitted these patients to the unit. They were very, very ill, critically ill. And one of the lessons we learned about COVID is they decompensate quickly. They could be there hypoxemic looking okay, and then all of a sudden. So it wasn't like I was doing this on the floor. I was still admitting them to the ICU and doing my high flow nasal cannula and my CPAP and my proning. And so it's not a less sick cohort. It was the same patients, just with different treatment strategies. So we're going to be publishing that soon. There's not a good publication, but we have now good data. We've looked at that. I'll share it with this crowd before publication, just a little bit. because I too believe that we shouldn't be doing academic science via New York Times and the LA Times, and we should be doing peer-reviewed publications. But we have found in a cohort study that we've shown decreased intubation, a twofold increase in less intubation, those that got high-flow nasal cannula or non-invasive versus standard care. All right, next slide. So that's lesson number 1. Lesson number 2 is about ARDS and COVID. And so I say beware of false prophets, because there's a lot right now, not in the peer-reviewed literature, but in the press, about there being 2 types of lungs in COVID pneumonias. You know, this really compliant lung, the soft lung, and the stiff lung, and stiff being the traditional ARDS, and somehow that COVID is different. And then that got a little traction by an Italian researcher named Gattinoni, who's had a good track record in ARDS, and so he has some clout, and that added to it. So I'm going to tell you again, there's not peer-reviewed data to say that that exists. And then I just read an article just published yesterday. They looked at the basis of their argument that somehow there's a difference in the attenuation in the lung, and basically looked at high-res CTs of compliant lungs and stiff lungs in COVID-19 ARDS and found no difference in the CT scans. So I don't believe it's true. I refer you to FLAIR. I think this is a nice way. It's fast literature assessment and reviews, and things are changing. It's put out by the Boston groups, the Harvard groups, and Boston U. And I think it's just a quick way. We're all busy that if you want to know, hey, look, what's the latest literature on that? They do a very nice job with that. So what is the evidence-based therapy for ARDS? Well, for many, many years, we have developed a very strong evidence of how to manage ARDS. It starts with the ARDSNet study in 1999 that showed that low tidal volumes versus high tidal volumes improved survival. This is important because one of the false prophet sayings out there is that if you have a soft lung, ventilate them with high tidal volumes, because it is easier to ventilate patients with high tidal volumes. And their gas exchange does improve if you ventilate patients with high tidal volumes. This was shown in the ARDSNet trial. But then after 3 or 4 days, those that had the softer lungs, even in the ARDSNet trial, and got the higher tidal volumes, all of a sudden got stiff lungs, and they have a worse mortality. But I always tell the residents and the fellows, look, the ventilator is not a treatment. It doesn't make the pneumonia better. It keeps patients alive until the pneumonia is healed, but we certainly can cause harm with the ventilator. And so I think we got to not throw away 30 years of research and understand that low tidal volumes protects lungs, and it saves lives. And that's your number needed to treat. For every 11 ARDS patients I manage with low tidal volumes, I save 1 life. Prone positioning in ARDS has also been shown to save lives. Nice article in New England Journal published about 7 years ago. And again, that's 16 hours a day for PO2 to FR2 ratio in 150. We do that also. And then conservative fluid management, the FACT trial, also has been shown not to save lives, but it gets people off the ventilators quicker. So we practice the evidence-based therapy for those who actually ended up on the ventilator, and also found that our mortality for ventilated patients is about 30%, significantly lower than what had been reported in Europe and some other centers. Other people are now reporting the same thing. So this study of 66 COVID patients intubated with a 34-day follow-up. This is out of the Boston hospitals, and they showed 62% were extubated and only a 17% mortality for those 66 patients. So the best evidence-based therapy that we've known for a while does work for ARDS and COVID, and I think that's the next lesson learned. Next slide. And then my last lesson learned is around thrombotic complications. We absolutely have learned there's something about COVID-19 that creates a more hypercoagulable state than the usual sepsis patients. We know that thrombocytopenia and elevated D dimers are associated with increased mortality. We know that there's increased now reports of deep vein thrombosis and PE in these patients. That was our experience early. We had some all of a sudden deaths that turned out to be PEs. And we also experienced frequent clotting of the dialysis lines. It was very, very difficult to dialyze. We tried heparin and low citrate baths, and that was probably our first hint that, hey, there's something different going here. All the dialysis lines keep clotting. How do we adjust to that? So low molecular weight heparin for everybody admitted, ICU or not, is our standard DVT prophylaxis for everybody with COVID. If you're admitted to the ICU, we do a higher intensity, lower molecular weight heparin for everybody admitted to the ICU. We have a very low threshold to fully anticoagulate patients. And if you develop renal failure, we fully anticoagulate you. We made that, because of all of our clotting dialysis issues, we made that as an automatic trigger. So next slide. So I want to thank you again for the time, and I appreciate you guys having me.
Everybody back on screen here? Ben, can you get everybody on screen? Let's see how we do this here. Okay, I'm not sure why that happened, but I was hoping to get everybody. Oh, gallery view. If you put your gallery view, then you can see all of us at the same time. Okay, we have a few questions, but before I ask the questions to all our panelists, I want to be able to let everybody know that we hope you stay with us till 10 minutes after 8 o'clock. We started a little late, and we want to go ahead and answer some of your questions. And I'm going to put a couple of questions together. This was in response to Nellie and Sylvia in particular about the care for Latino patients. One, did you see patients have anxiety because of having grandparents or elderly parents in their homes, especially with isolation? That's one question. The other one is about the undocumented. And did you learn anything about the undocumented, that we already know how marginalized undocumented are in our communities? But any lessons learned? We are here to hear your strategies on what did you tell your patients or your colleagues about having the elderly at home by themselves or the undocumented? And I just want to ask Sylvia and Nellie first, and then Leo, I'll get you a question.
Okay.
Go ahead.
Go first?
Would you like me to share?
Sure.
Go
just
ahead.
very brief, just a Latino story.
Well,
Would you like me to?
I'll do a Latino story. We had some of our workers who have children at home, and they were fearful that their children would be infected. And one of our midwives lived in the same house, but she sent her baby to live downstairs with her mother, and she didn't see the baby at all. The baby was angry at her because knew that she was upstairs, but was not coming down. But some people sent their children away if they were able to do that. If they were divorced, they sent them to the spouse. But one of the things that we noticed was that the fear, like Sylvia said, and I think that teaching and telling people, this is transmitted this way, wash your hands, use protection, use masks, take a shower or, change your clothing before you get in touch with your family or you cook any meals and things like that. And that helped a lot, especially at the height of the epidemic, because people got sick and they had to, self-isolate themselves from their families. And it's very hard. If you're
anything on undocumented lessons learned?
Well, a large proportion of our patients in Health and Hospitals Corporation is undocumented, and they don't get any different care than everybody else in the hospital. But one of the things that is the fear I get a phone call from somebody in Mexico asking me if I could find a doctor for somebody who was a relative in New York who needed to be seen because he was afraid that he was very sick with COVID, but was afraid to go to the hospital. And I gave them information about access to care and Health and Hospitals Corporation, and the fact that anybody, regardless of insurance or ability to pay, can actually be seen and be taken care of acutely. And that at that point, there was nothing to be afraid of.
Okay. Sylvia, anything to add?
Yes, I have one story of a cook, because see, when we talk about who are the high risk individuals, we always talk about healthcare professionals, nurses, police officers, firefighters. But actually what I discovered and what I would say is that cooks, housekeeping, they're also were at high risk, and they were on the front line because they were the ones that we forgot about giving the PPE to, and we're walking into patients' rooms and actually getting rid of all the old PPE. But the story I have a cook that worked at one of the nursing facilities, and this cook developed COVID-19, and this cook continued to work. And so what the problem was, when I asked him, why'd you keep working? He said, I was so scared, how am I gonna feed my family? And I don't know, do I still have a right, because I'm undocumented, to file for unemployment? So what we did is we partnered with a lawyer, and this lawyer came out and helped this individual fill out his forms for unemployment. So I thought that was a very good story, because these are stories that we're gonna see over and over again.
Okay. Leo, I have a question for you about technology. You're surrounded by ventilators and all this huge technology as you treat your patients. Could you talk about what's the role of technology before people get sick? And one thing that was mentioned is mobile units.
Yeah.
And are you involved with that with your Ochsner health system?
Yeah, great question. I think with telemedicine, we've been trying to get traction with telemedicine and do more e-visits, and the COVID-19 pandemic has really accelerated that. To give you an example, we did 3,000 telemedicine visits in all of 2019. We did 100,000 televisits in April and March. So technology has really been crucial to the way we've been able to manage and get through this. On the mobile units, what we've done is we've created strike teams and community testing teams that go to the community. And I guess my answer to undocumented, I don't have an individual case to that, but I think the ability to get into the communities, one of the things we saw a big spike early in African Americans really bore the burden of disease in the New Orleans area first. And then later, we saw a rising spike among Hispanics. And it really was about a month later that we started to see a big burden among the Hispanics. And a lot of that had to do with, as we set up testing centers, there was great fear to go and get tested, especially if you were undocumented. And so getting into the communities, working with the community leaders and these mobile testing units that would go into the Latin American community, work with the local community leader to reassure the population it's okay to get tested. We're not going to get any more information than we need to be able to get you back your test results. And then also translating a lot of the public service announcements that were in English, because we're not as big a Hispanic community, into Spanish was another big part of that. And I think the last thing I'll say on technology is we have symptom trackers. We're an Epic shop, so we have the electronic medical record, and we have symptom trackers and a hotline call line that I'm Medical Students Health Man. And what that has allowed us to do is that as we got kind of a quasi-contract tracing within a health system, as all the public health systems were kind of overwhelmed, that when we got patients that tested positive, we put them on our symptom tracker. All of their relatives and all of their close contacts would be on the symptom tracker. And that way, as soon as they start to develop symptoms, electronically through my chart, we would communicate with them. They just log in their symptoms, and then the my chart would say, hey, we're concerned about you, time to do an e-visit, and then we can bring them in to get tested or the like. So technology has played a big role in how we manage it.
Okay, I have a question for Nellie, actually 2 questions. And Nellie, if you can answer them very briefly. One is, do you think Governor Cuomo, who got a lot of visibility, still gets a lot of visibility, did everything for your hospitals that he said he was going to?
My opinion?
Yeah.
I think he did an excellent job, as did Mayor de Blasio, because I think that this was a changing scene every day, and they had daily conferences where they announced what the next steps would be.
Yeah.
I think there was some conflict between them, but they managed to do, the right thing for the communities. I think New York City could have closed the schools a little earlier. That might have tapped the epidemic sooner. But for the most part, I believe that both of them did a really good job.
And the other question to Nellie, and this is really because New York has been the epicenter in the United States. It seems that from the person who asked this question that a lot of people were told to stay home and not go to the hospital, not go to doctors. And there may have been some confusion, but what do you think is what's a good message going forward? What is the message on when people should go to the doctor?
Well, because about 80% of people who get this disease are either asymptomatic or have very little symptoms. At the beginning, people were, actually, since we didn't have testing that easily, we symptomatically looked at them, and if their SATs, if their oxygen levels were high and they seemed to be doing okay, they were sent home with instructions to come back. However, there were cases where people were sent home and told to come back, and when they came back, they were more drastically ill than at the first time that they presented, and some of them, did code and die in the emergency room. And again, I think New York City was at the beginning of this, and I know that one night I was on call. I wasn't on call in the COVID unit, but my colleague was, and we had like 15 transfer patients from another hospital in Queens who had been bombarded with cases. And at one night it just started, and from there our volume went up, like in the 200s. And we, many of the people were being intubated, but again, we also discovered that if they were not intubated, some of them actually did better. So they were put in the unit, or they were put in close observation units. I mentioned we had a close observation unit in our PACU. Overnight, the PACU became a 15-bed COVID unit. Overnight, the clinics became COVID units. And we had construction people everywhere, knocking down doors and, making new areas overnight. So it was incredibly accelerated learning. We had to learn.
No, a lot of good experience too from all of you.
Now about
Sylvia, one quick question, and then Leo, one quick question. Isolation in the nursing home patients that you saw, what do you think the impact is on the families? And, again, Latino families being very close and wanting to see their elders inside the nursing homes. What did you see?
Well, what I saw, number one, the social isolation from the families, especially with Latino patients, is horrible. We saw a lot of physical manifestations to depression and anxiety, such as weight loss. And when I tried to figure out why are they losing all this weight, it was because their family members were taking them food to the nursing homes, and now they were not allowed in. So we saw a lot of that. And as far as being isolated, it was just horrible. I agree with, there's a lot of technology and telemedicine and all this, but with the Latino community, you really want to hear that voice. So we had a lot of the nurses calling them on the phone, recording their voices, letting them do FaceTime,
Okay.
but it was devastating. And we're starting to transition them out into, I hate to say this, but into parking lots so that they could see their loved ones
Oh, good.
in California. So that was a positive.
Thank you. And Leo, last question. And well, I'll make a comment on a few other things, but obesity. What do you think? We've heard it in the news, and there was some questions, and I know with heart disease and with diabetes in our families, we see a lot of obesity, especially, well, in the United States, obesity everywhere.
Yeah.
What was your impression of?
Look, it's clear it is a risk factor, and in fact, we're finding diabetes and obesity are the two highest risk factors for developing complications from COVID-19 and getting hospitalized. And then the New England Journal article that we published, that got published last night, had a print. If you look at the risk factors for hospitalization, obesity, diabetes, and actually African American was an independent risk factor for being hospitalized. If you look for risk factors for mortality, again, obesity and diabetes play out.
Okay.
So yes.
Okay, well, thank you. I want to thank all of the panelists. We got a lot of great comments on all of your great experience. And I have to say that the National Hispanic Medical Association was started to be able to collect the great experience of our members. And we would like joining us tonight to be sure and join us again on July 24th, which will be, I guess, I'm sorry, June 24th is a Wednesday, where we are going to be focused on mental health. I think Ben had a slide. Ben, do you have a slide? The next? Yeah, so June 24th will be Latino COVID-19 and Latino mental health. And we are also going to talk about not only the patient's mental health, but the resilience needed for our healthcare workers like the doctors tonight, who are getting burnt out with all the extra work that has to be done with all of these new challenges. And then in July, we are going to hear about impact on our healthcare delivery and what is the new normal for healthcare delivery. And we are going to talk more about technology and telemedicine. I think another issue is just how are referrals done to keep patients out of hospitals. They need to go to doctor's offices and they need to go to clinics, but so many people just didn't know where to go. And they still go to emergency rooms. So we need to look at that. And then the last thing I wanted to say, we got a few questions about the National Hispanic Medical Association and what are we doing to find more doctors and nurses. And it's apparent that with the high rates of infection and the high rates of hospitalizations that we talked about tonight, that we need a lot more Latino doctors and nurses. And we do have a program on our website at nhmamd.org. It's called the NHMA College Health Scholars Program. And we help students with information about financial aid, about scholarships, and how to find a mentor. We also ask doctors and nurses and others to help us be mentors for the young students. The other thing that was asked was, are we helping international medical graduates? And Leo, let me just ask you, does the Ochsner Center have any special program for the IMGs, knowing that you are affiliated with a foreign country, with Australia?
We don't have any affiliation with other IMGs. We certainly have a scholarship for Hispanic students to attend our med school. And Elena and I have talked a lot about this, is we're developing pipeline programs locally going into the high schools and elementary schools, and then creating the Big Brother approach for undergrad students to keep Hispanics interested in being medicine and learning that just because biochemistry is tough, don't give up.
Mm-hmm. Okay. Well, the reason I ask is because I know, and Nellie, I know you wanted to say something, but let me just say that NHMA has a group, an interest group of international medical graduates. And what we would like to do is offer more experience from them on what they're going through so that we can help them. And there's such a need. I know that the licensure, because of the pandemic being an emergency situation, some of the licensure requirements were changed so that some of the IMGs could actually work in certain states. I know Virginia did it here in the East Coast. California did it. And I believe New Jersey and New York also made some changes. But Nellie, you had a comment about?
I have a comment. We at Einstein have several pipeline programs. And what we did this year, instead of canceling it, is we combined about 4 or 5 programs. And we're going to have a virtual curriculum for them, including research and clinical, and they can't shadow, but we're going to try to make it real for them, so that to encourage young people in STEM to go into medicine and all the health professions.
Okay, great. Well, with that, I want to say good night, and again, thank you very much to the panelists tonight. Dr. Correa, who's actually our new chairwoman of the board of directors of NHMA, Dr. Preciado, who's on our board of directors, and Dr. Sioni from New Orleans, who's our chairperson or chairman of the NHMA Gulf Coast chapter. And we look forward to working with all of you, and we look forward to having more of participants as we move forward. We're having monthly webinar series to be able to again, showcase the phenomenal experience of our own doctors and our networks. We work with nurses and dentists and other minority groups. We work with the Black and Native American and Asian doctors too. And I think it's just so important to showcase what we know and to share with those who take care of the Latino and Black and Native American patients. So thank you all. And let me thank Ben and all our staff.
Don't want to leave without thanking you, Elena, for your great leadership and for the amount of effort and work that you put into all of these endeavors. So
thank you. And thank you to all the partners. We were very pleased to have the different partners that we had tonight. So thank you very much.
Good night.
Good night. Good night.
Good night.